Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Scott Olson, a pediatric infectious disease specialist at Banner University Medical Center in Tucson and Associate Professor of Pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the debonair young man on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks for tuning in today. This is the week of November 3rd, 2025. Let's go ahead and jump right into the questions. Our first question of the week comes from an Arizona AAP member who asks, can you provide an overview of the kissing bug disease and its prevalence in Arizona? Also, if testing is needed, how to test and what tests are available. So the kissing bug disease is called Chagas disease and is caused by infection with the parasitic protozoan organism Trypanosoma cruzi. And this parasite is carried by infectious triatamine insects, also known as kissing bugs. Most human infections with Chagas disease are thought to be the result of exposure to these infectious vectors. However, it's also important to note that transmission has occurred as a result of infected blood products, organ transplant, and importantly, congenital infection. With regard to vector-borne infection, transmission occurs after the insect feeds on a human, typically at night, and then the bite wound is infected with feces from the triatamine insect. These insects are endemic in 21 countries in the Americas, and while it's not considered endemic in the United States, transmission has occurred in the southernmost states as the triatamine vector does live in older mud adobe homes. So while classically it's thought of as a disease in developing countries, Chagas disease can occur in impoverished parts of the United States as well. And as such, there has been autochthonous transmission in states such as Texas, New Mexico, Arizona, and California. Interestingly, while infection is rarely identified in the United States, studies on the triatamine insects have demonstrated that they do carry Chagas disease in fairly high percentages. So, for example, there was a study here in Tucson, Arizona, where triatamine insects were tested for Trypanosoma parasites and actually found that 41% of those insects that were tested did carry disease. So why is it that if so many of the insects carry Trypanosoma, there aren't more infections identified in the United States? Well, interestingly, it does seem that the behavior of the bugs in the United States is slightly different than in other parts of the world where disease is endemic. So, for example, the triatamine bugs in the United States tend not to defecate until later after a blood meal, meaning that even if someone is bit in the United States, it's unlikely that that bite will be contaminated by the Trypanosoma parasite. Additionally, studies on the insect in the United States show that even in homes where the insect is present, they tend not to be in as high a concentration, meaning that it's probably less likely individuals living in the home will be bitten. And as a result, Chagas disease in the United States remains relatively uncommon. So, for example, in Arizona, where Chagas disease has been reportable since 2008, there have been, on average, about less than 10 cases per year reported, and I could only find one report of autochthonous or locally acquired transmission among pediatric patients, and that case was actually written up in 2018 by former host of the podcast, Dr. Sean Elliott. Within Arizona, most cases of Chagas disease have been reported from Maricopa County, and most of them were thought to be imported cases from the patient's country of origin. This year in 2025, based on data from the Arizona Department of Health Services, there have only been 4 reported cases of Chagas disease. Additionally, I did some research and actually couldn't find any reported cases of congenital infection from Arizona. When we talk about the actual disease associated with Chagas, there's 2 phases that we like to discuss, and that's acute and chronic infection. Acute infection occurs within the first 8 weeks after exposure, and it can be a spectrum of illness ranging from asymptomatic to life-threatening disease. Classic signs of Chagas that you'll see in textbooks include swelling of the eyelid, called Romagn's sign, a nodule or chagoma at the site of inoculation with surrounding skin induration, and these symptoms can be associated with systemic findings such as fever, rash, vomiting, hepatomegaly, splenomegaly, or lymphadenopathy. Rarely in the acute phase, you can have life-threatening myocarditis or meningoencephalitis. However, these manifestations are noted to be rare with Chagas disease. Then after the acute phase, symptoms can fade during the indeterminate phase, and about 20 to 30% of those infected will progress to the chronic phase of disease about 10 to 40 years after the initial bite. In the chronic phase, patients have undetectable parasitemia, but go on to develop severe life-threatening cardiac or intestinal complications. Mothers with untreated infection can also pass Chagas disease to their infants by a congenital route, and those infants during early life can also be either asymptomatic or minimally symptomatic with congenital infection. If unidentified and untreated, however, those infants, like adults, can progress to chronic disease and develop cardiac and intestinal complications similar to what is seen in adult chronic disease. Infants that are symptomatic with congenital Chagas disease have been reported to experience low birth weight, preterm birth, anemia, thrombocytopenia, hepatomegaly, splenomegaly, pneumonitis, and potentially anasarca. Because affected patients and infants can be asymptomatic or minimally symptomatic, the first aspect to diagnosis is having a low index of suspicion, particularly if mothers are from endemic areas. To diagnose Chagas disease in the acute phase, occasionally the parasite can be visualized with a blood smear sample. However, testing with DNA PCR currently is considered the most sensitive and specific diagnostic assay. To diagnose chronic disease, most individuals may not have positive PCRs during that phase, so testing with Chagas serologies is recommended. And for congenital infection, while most people recommend sending a DNA PCR test, I would probably recommend doing both PCR and antibody-based assays. Here in Arizona, I know that PCR testing is available through ViraCore, and IgG serologies are available through ARUP. And just to finish, while the original question didn't ask about treatment options, I'm going to quickly review that just for completeness sake. If you are treating congenital infection up until 2 years old, most recommendations are for the antiparasitic called Nifurtimox, which I'm sure most of us have not used before. Older than 2 years old, the antiparasitic of choice is benznidazole. Again, I don't anticipate most pediatricians in the community will be treating Chagas disease by themselves. However, I think it's nice to be aware of what treatment options are. Moving on to question 2, another AAP member wrote in to ask, can you speak about the emerging trends in antibiotic-resistant organisms regarding neonatal sepsis care? In brief, like lots of other environments in healthcare, we are starting to see increasing rates of resistant organisms in infections in the NICU. However, the rates have not been high enough that at this point I think it's worth readdressing or changing our empiric antibiotic options for sepsis or infections in NICU infants. Obviously, if you are treating a resistant infection, then you'll be using an expanded spectrum antibiotic agent. However, for routine empiric management, we'll go through the numbers about why I think AMP and GENT are still the best first-line agents. When we look at the incidence of early-onset sepsis, a study from JAMA Peds in 2020 estimated a rate of about 1.1 per 1,000 live births for all ages. However, early-onset sepsis does occur more commonly among preterm infants with gestational ages of 22 to 28 weeks, with a rate of about 13.9 cases per 1,000 live births, according to that same study. And not surprisingly, because rates of infection are much higher in this age group, about 3/4 of extremely low birth weight infants will receive antibiotics after birth. However, this rate is much higher than 14 per 1,000 actual cases of sepsis, raising a concern that overuse of antibiotics in this population could lead to further selection or emergence of resistance within this high-risk patient population. So when we discuss the concern of early onset sepsis, and specifically with resistant organisms, the question becomes, first of all, which infants actually require antibiotic administration? And then is there a way that we can identify those who are at high risk for infection with resistant organisms? The first thing to say here is that there are tools to help in identifying which infants are low enough risk that they do not require antibiotics. The most commonly known tool that I think most providers are aware of is the neonatal sepsis risk calculator, freely available online from Kaiser Permanente. This tool is very useful at identifying low-risk term infants who will not need antibiotics following delivery. But for those infants who are at higher risk for infection and therefore do merit empiric antibiotic administration, I think it's important to talk a little bit about the changing epidemiology of early onset sepsis, because this is going to inform our discussion about which agents are appropriate. Since the beginning of routine GBS screening in pregnant people, GBS has been replaced by E. coli and other gram-negative enterics as the leading cause of early onset sepsis for preterm infants, with rates of GBS and gram-negative enterics being about equivalent for all age groups. Now, this can put us in a tricky situation because the gram-negative enterics, including E. coli, are the biggest concern we have for the emergence of resistant organisms, in particular extended-spectrum beta-lactamase producers, which can frequently carry additional resistance genes, making those organisms resistant to additional antibiotics such as trimethoprim sulfamethoxazole, aminoglycosides like gentamicin, or fluoroquinolones. Rates of resistance among gram-negative enterics and E. coli can vary widely across regions, so it's definitely important to look at your local antibiogram to figure out what the rates of resistance among E. coli in your community are. Among E. coli isolates specifically, reports of resistance vary against ampicillin from 66 to 80% and against gentamicin from 8 to 17%. And therefore, it's possible to have an E. coli early onset sepsis infection with an organism resistant to first-line agents ampicillin and gentamicin. And a 2021 study actually estimated that about 1 in 10 E. coli isolates associated with early onset sepsis would be resistant to both first-line agents. However, this data does conflict with a CDC survey from 2005 through 2014, which only found that 1.7% of isolates were resistant to both first-line agents. And while those rates seem relatively low, because of rising rates of community-acquired resistant gram-negative infections, and because the infant's infections tend to come from the maternal microbiome where resistant organisms may be harbored, there is concern that with increasing rates in the community, we might start to see those rates creep up within our NICU infants as well. Anecdotally, I can think of 2 infants hospitalized within the last year here locally who had an E. coli urinary tract infection, which was resistant enough that the infant needed to stay in the hospital for the entire treatment course with parenteral antibiotics. And while these rising rates of resistance against ampicillin and aminoglycosides may beg the question of why we don't just use more broad empiric agents, I think it's important to remember that older studies in NICU cohorts did demonstrate that those infants who were treated with cephalosporins instead of aminoglycosides had higher rates of all-cause mortality compared to those infants treated with gentamicin, possibly due to dysbiosis from overly broad antibiotics, emergence of resistant organisms, and increased risk of Candida infections, which can be severe in preterm infants. So while the emergence of resistant organisms in infants is concerning, I think it's important to go back to those initial numbers about the overall incidence of sepsis to really hammer home why AMP and GENT are probably still the best first-line agents. So if we go back to those initial rates and look at all infants, as we said, there's about 1 infection per every 1,000 live births. And if we assume that maybe about 10% of those are resistant, that would be 1 in 10,000 infants would be resistant to first-line AMP and GENT. If we then look at the higher risk preterm infants, as we mentioned before, there's about 14 infections per 1,000 live births, and around 1 in 1,000 infants in that category will be infected with an organism resistant to both ampicillin and gentamicin. So even in the highest risk preterm infants, the rates of infection with resistant organisms are low enough that it doesn't make sense to expose all those infants to expanded spectrum antibiotics, especially when you remember that, as I mentioned before, about 3/4 of these preterm infants will be treated with antibiotics empirically. So in light of these estimates, I think that the AAP early onset sepsis guidelines from 2018 still are adequate for management of infants at risk for sepsis. And based on those guidelines, they did mention that empiric broad antibiotics can be indicated in critically ill infants until culture results are known, or in preterm infants who are ill and at risk for early onset sepsis, particularly if prolonged antepartum maternal antibiotics were administered. Additionally, though this isn't in the guideline as far as I remember, I would add if you have a sick infant whose mother had a confirmed resistant infection, it may be appropriate to use more broad antibiotics until the culture data is known. Thankfully, though resistance to first-line ampicillin and gentamicin have been a concern, as we've discussed, ESBL and carbapenemase isolates are still very rare in early onset sepsis, so in those circumstances where you're concerned about resistance, broadening to a cephalosporin-based therapy is probably still going to be appropriate even in the context of resistance. And question 3 this week asks, to limit unnecessary antibiotics, what biomarkers help distinguish viral versus bacterial infection? In brief, the inflammatory markers that are currently available to clinicians for use, namely C-reactive protein or CRP and procalcitonin or PCT, do have moderate accuracy in distinguishing bacterial from viral causes of routine pediatric infections like sinusitis or pneumonia, but neither of them are sufficiently specific or sensitive enough to be used in isolation for clinical decision-making. CRP is generally higher in bacterial infections compared to viral ones, but there's a pretty substantial overlap such that typical cutoffs yield sensitivities of only 77 to 94% and specificities of only 63 to 82% for a bacterial etiology. Procalcitonin has been shown to be a little more specific for bacterial infection compared to CRP, but its sensitivity and specificity are still only considered moderate. For example, a meta-analysis in children with pneumonia showed a sensitivity of procalcitonin of 55 to 68% and a specificity of 60 to 76% for bacterial infection, depending on the cutoff used. So in general, I would say that both procalcitonin and CRP are useful tools to support clinical judgment when deciding whether or not an infection is bacterial or viral, but it shouldn't replace the clinician's clinical judgment. Because these biomarkers don't offer a perfect way to distinguish bacterial from viral infections, recent studies have been looking at larger panels of combinations of both old and newer biomarkers with some initially encouraging results. These studies have been using procalcitonin or CRP in combination with newer markers, including bacterial and viral-induced host proteins, such as TNF-related apoptosis-inducing ligand or TRAIL, interferon gamma-induced protein 10 or IP10, myxovirus-resistant protein A or MixA, or human neutrophil lipocalin or HLN. These studies have shown improved test characteristics when compared to CRP or procalcitonin used alone. However, when we look at one study that was evaluating the combination of CRP and Mix-A, they showed good sensitivity, negative predictive value, and specificity, but the positive predictive value was still only about 50%, meaning that even with a positive result, only half of those patients actually had a bacterial infection requiring antibiotics. So while some of these panels may be useful to screen out lower risk individuals who don't need antibiotics, my concern is that still half of the individuals receiving antibiotics based on these results would actually have a viral infection. In general, with the biomarkers we have available currently, namely CRP and procalcitonin, I would say that they have a decent negative predictive value, especially with serial results, so that it is a way to help distinguish which patients may not need antibiotics. But because the sensitivity and specificity for distinguishing viral from bacterial infections in children is still not very great, I would say these tests should be used more to complement your clinical decision making as opposed to using them as the sole determinant as to whether or not your patient requires antibiotics. And our fourth and final question comes from a member who wrote to ask, as we head into the typical vaccination season, how do Arizona's pediatric immunization rates compare to previous years? Well, overall, nationally, immunization rates among children have been dropping since the beginning of the COVID pandemic. Now, the CDC has been following annual kindergarten vaccination rates nationally and by state, and what they've found is that overall exemptions from one or more of the kindergarten vaccines has been climbing across the country over the last decade. And for example, for the 2023-2024 school year, 3.3% of kindergartens nationally had an exemption for one or more vaccination. And if you compare that to the 2024-2025 school year, 3.6% of U.S. kindergartners had at least one exemption, with 17 states reporting exemption rates greater than 5%, which is a concerning trend in light of this year's measles activity across the country. When we look at Arizona specifically, in general, our trends of childhood immunization have been a little worse than the national levels. If we go all the way back to 2011-2012 school year, the exemption rate among kindergartners in Arizona was only 3.7%, but then by the 2023-2024 school year, 8.5% of kindergartners in Arizona had at least one vaccination exemption, and that level was up to 9.1% for the 2024-2025 school year, with almost all of those exemptions being non-medical. So overall, Arizona appears to have lower vaccination confidence for children, but how about specifically with respiratory viruses? Well, to get a better handle on these specific viruses, the best example is annual influenza vaccination. Unfortunately, similar to overall vaccination rates among children, immunization rates against influenza have also been dropping in the last several years. So, for example, the CDC tracks the number of immunizations nationally, and for the 2023-2024 influenza season, the CDC showed that in the United States, 55.4% of children over 6 months received at least one dose of the influenza vaccine, down from 57.4% the prior influenza season, and down from levels in the pre-COVID pandemic era of 63.7% in 2019-2020, which is concerning, especially in light of the most recent influenza season, which was one of the worst seasons since the 2009 H1N1 pandemic. In this same CDC study, they showed that the vaccination rate for children 6 months to 4 years old didn't change from the prior season at 64.2% of children. However, rates among older children dropped by over 2 percentage points. And the study also revealed that 30% of children had at least one vaccine-hesitant parent, reflecting the reality that after the COVID pandemic, vaccine hesitancy is more widespread. And we don't yet have full data from the 2024-25 season that I could find. However, preliminary data halfway through the season suggested that only 49.2% of children in the U.S. had been vaccinated. Specifically in Arizona, vaccination rates among children have been dropping for the annual respiratory virus immunization, similar to the trend seen for kindergarten vaccination rates. And as of November 2024, 30.5% of children in Arizona had been vaccinated against influenza. Now, again, I don't have the final numbers from the most recent season, but the last full season of data from 2023-24 demonstrated that in Arizona, only 52.2% of children had been immunized against influenza in that season, which was lower than the national average of 55.4%. So again, overall, nationally, we are seeing declining rates of immunization among children, and it seems like that is a little more pronounced in Arizona compared to the national average. So in general, we still need to do a better job of encouraging our families to consider immunization. Thank you again for listening. Remember, AZAAP members can submit questions for future episodes to id@azaap.org. The AZAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant Funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.